Can you hear me
Yes.
clear?
Yeah.
Okay, great. Okay, so everybody, I'd like to introduce you to Dr. Andy Tan from Sincere. But before we start today's talk, which is a very interesting one, I'll leave Dr. Andy to give a quick introduction and tell us more about what he does.
And thanks for the invitation. Yes, I'm Dr. Andy Tan, and I'm practicing currently now in Gleneagles Hospital in Annex Block and with the Sincere Health Group. So just slightly regarding about myself. So I specialize in endometriosis surgeries and also a minimally invasive surgery. So 4 or 5 years back, I spent a year specializing in terms of endometriosis treatments, advanced treatments in Denmark. So yeah, that's about me in terms of a subspecialty. So why is it that I have passion about endometriosis? Is because that, I mean, as we know, the endometriosis can be quite detrimental and it can cause severe pain as well as an infertility problem. So yes, as much as we can, of course, we want to help patients suffer from endometriosis. Yeah.
Yeah, definitely. Endometriosis, we hear that very, very often, you know, in our fertility circle and this and that. So today's talk is obviously not only about endometriosis, but we're going to start with abnormal uterine bleeding and painful periods. So maybe you can start off by telling us what is abnormal uterine bleeding.
Okay, so in terms of abnormal uterine bleeding, it's let me just I think you have the definition there. Yes. Okay, so apart from endometriosis, of course, another condition that someone comes to a gynecologist will be abnormal uterine bleeding. So we know that every woman in their reproductive age, they go through the each cycles. Once you achieve menopause, you will have menses. And the first time that we had a menses is called menarche. Okay, that's a medical term. Usually happens 9 to 12 years, 9 years old up to 12 years old. And it can be early as 9 years old. So when it comes to abnormal uterine bleeding, we will just look at the definition. Okay, so mainly is what we call this derived from a FIGO definition, is that your cycle should be varies between 25 days up to nearly about 40 days. So that's considered a normal menstrual cycle. And then your flow should be between 3 to 7 days, or even 2 to 7, should not be beyond 8 days. And of course, another category is then how to assess your volume of the flow.
Yeah.
So in terms of volume, of course, is by your objective assessments, and you find it is very heavy, is there clots. But in the terms of objective assessment, we don't usually do it, is that the measurements of the flow each cycle should not be more than 18 mils. And then these are the few parameters, I would say about 4 parameters that we should look at it. And those who have abnormal bleeding, is like probably you can see from the slides, is that your cycles is out of place, or you have bleeding prolonged, you have intermenstrual bleeding, then you should seek medical advice as early, because depends on the age group. Of course, in the early age group, it can be due to hormonal conditions such as thyroid conditions and all that. But if, of course, you are above 40s, we want to rule is it due to the cause from the womb lining or the womb itself. Yeah.
So in terms of, for example, you said, do all women experience this, or is it just like basically only if you experience this, then you should see a doctor?
Okay, I would say that not all women will experience that, okay? But it's in terms of prevalence-wise, I would say that about 1/3 of women would then experience this throughout their kind of reproductive age. Okay, the more common one, as I mentioned earlier, when you start to have period, because that's maturity hasn't reached yet, so the ovulation cycles may take time. So the early age group, for example, the adolescents, when they start to have period, they can have this. Okay, most of the time they are not something that's serious, but you will need to assess. However, there's a condition if, let's say, during the first time the period and from the start, I would say a lady that already started to have heavy period, yes, then you need to find out, is it due to coagulation, or we call that clotting problems. All right, very, I mean, of course, I would think that in Singapore context, probably it's not so common. It's called that something called von Willebrand disease. Is actually a factor that's the deficiency that causes heavy bleeding. So this is one of the category. Yeah. So in terms of early women or ladies that have bleeding problems. And of course, it could be other causes like thyroid conditions and all that. And another category is that perimenopausal. So when you're perimenopausal, it's same thing, and of course that's when the depletion of the eggs and all that. So then the ovulation probably has a problem. So these are the two usually categories that if you experience abnormal uterine bleeding, for I would say benefit of doubts, should advise to go to seek a medical treatments and to make sure that it's not something that's serious. Yeah.
When you say go and seek medical treatment, you know, some people say, who do I go to? Do I go to a GP? Do I go to a gynae? Do I go to a fertility specialist? You know, who specifically are we looking at?
Okay, I will say that in our context, I think family physicians, usually a primary physician or GPs, I think it's usually the first healthcare contact would be one to go to. So I think it is fine because most of the GPs, or I would say all the GPs, they know what they're dealing with. Of course, if you have significant condition like this, I think that it will be a role to go to a gynecologist. They will refer you to a gynecologist with or without a referral letter or their advice. And I think if it's put it in a way, if let's say for someone who had experienced it, like for example, if a mother who experienced this problem and then they have a fibrosis, of course, from that they may they ask their daughter to go straight away to see a gynecologist. So it varies, of course. That when I say medical advice, is that you can see a GPs, from there you move on. And of course, that if it doesn't improve, then you should see a gynecologist, but you should deal with the gynecologist. Yeah.
Understand. Okay. So as long as you seek medical advice, that's the main thing.
Yes.
Okay. Now let's go into symptoms. I mean, is there certain things? So just now, I know you talked a bit about this just now. So there's two extremes, I guess. There's the extremes of not having your period regularly and then too much, right? So at what point in time, I mean, how long does this have to prolong for before you say, okay, something is wrong?
Okay, I don't have to answer that. I mean, of course, as long as that you find that something, okay, usually you have this period, like this has been regular. I think that if it becomes abnormal, for example, you never experience painful period, but suddenly you experience, of course, then you can observe for 1 month, 2 months with the painkillers and it resolves, that's fine. But however, it continues progressing, getting worse or getting worsening. I think within the time frame of 1 to 2 months shouldn't be an issue. But what most important is that, of course, when you start to have heavy bleeding, it's not just the symptoms and bleeding itself. You also be assisted with what we call anemia. Your hemoglobin can drop. So it's difficult to gauge. Of course, if you ask me, if something that's unusual compared to what you had, medical, what do you call that? It's easy accessible. So of course, if you can just advise and all that, and then see what's the next step. Yeah. So that would be my advice. Yeah. And
the reason why I ask is because sometimes I know ladies said, oh, I'm very stressed this week, this month. So therefore, my period is not, as per usual, or they say, okay, my last few months are going to be quite stressed. So, should we tell them, okay, no, maybe, stress can be a certain factor, but, you should still go see a medical, seek medical advice.
Yeah. So I would say that yes. I mean, in terms of stress, like you pointed out very clearly, is that it causes the variation in the period. Because the stress then becomes abnormal. I would think that a good period would be within 3 months. And of course, the progressing worsen for more than 6 months. Yes, you definitely need to seek advice. Yeah.
Fair enough. Okay. Apart from the standard of too little period or too much period, are there any other symptoms apart from pain that they should look out for?
I would say that in terms of abnormal uterine bleeding, these are the 4 main variations that we look at. And when you say that any other symptoms, I guess that probably is there. You feel any symptoms of pain, bloating, or even a mass that you can feel yourself, or even sometimes some abnormal vaginal discharge, that also can be something that's abnormal. So these are the things that's on top of the abnormal uterine bleeding that probably warrants a medical check as well. Yeah.
Okay, fair enough. All right. And then then let's go on to when a person faces this and they come and see a doctor and the doctor sends them to a gynecologist. what checks can be done at the end of the day?
Thank you. So, I mean, in terms of gynecology or even the doctors and all that, of course, first important is mainly your symptoms and how that the many things that it will be asked. So, generally, from a gynecologist viewpoints, would be of course the gynecology history, and in terms of the whether whether you're sexually active, whether you're married with previous pregnancy before. So these are the most important things that we want to know. Okay, and then the second thing is that based on the abnormal uterine bleeding, okay, so the amount of bleeding, whether any other symptoms such as anemia and all that. So that would be part of the initial assessment, and then when it comes down further, is that whether apart from the symptoms, whether you have fertility desire, because it will affect your treatment. So and these are the few important. And I can see from here, you also will be asked about any other symptoms such as bleeding problems in your history, any family history of endocrine problems and all that. So if you are sexually active, and whether you have past pap smear, which is the important thing to check when you are sexually active to rule out cervical cancer, and of course the sexually transmitted infection as well. Is there any previous history? Yeah. So and then that's usually roughly most of the gynecologists or even the GPs will ask. Yeah, before assessing further, like such as a blood test and all that. Yeah, and a physical. Yeah.
In terms of blood tests, I mean, what kind of blood tests can be done?
Okay,
is it a normal blood test?
Yeah. So in terms of, let's say, when we are now specific on abnormal uterine bleeding, so depends on, of course, that how heavy is the bleeding. If there's any symptoms or even the signs of anemia during examination, the most basic one will be a full blood count. We call complete blood count, is to check on your hemoglobin whether you're anemic. Okay. At the same time, of course, if there's a sinus infection, you will also reflect whether increase of white cells. That will be the sinus infection. This is the minimal, and of course, the irons can be checked whether you are, iron depleted or you are lack of irons. And other checks will be endocrinological, such as hormonal. All right, so hormonal check will include like your thyroid functions, because this also can affect your bleeding problems. Yeah.
Wow. So at the end of the day, it's not that straightforward. I guess that it can be due to a lot of different problems at the end of the day.
Yes. So basically, I would say that I'm not sure whether you have it. That I mean, in terms of when we say about abnormal uterine bleeding, the FIGO has come up with a kind of very simple. I wouldn't say mnemonics, but it's something that someone will look into. Is actually either pathological conditions or other conditions. So it's palm coin, we call that. So right, palm is either whether you have underlying polyps that causes bleeding. You would have that.
Yes. So before we go into that, this is the pelvis. Yeah. This is the ultrasound of how you do the pelvis.
Yes. Okay. So this is in terms of investigating when you see a gynae, apart from examinations, check. All right. We will also check the ultrasound. Okay, because it gives us a lot of information and to look for either fibroids, other conditions such as adenomyosis, the polyp, and all that, or even ovarian masses and all that. So this will of course boils down to what is the treatment need to be given. Yes.
And all those kind of things can be seen on an ultrasound.
Yes. Majority, of course, it depends on it's operator dependent, of course, and also whether is it a transabdominal ultrasound or transvaginal ultrasound. I would say preference will be a trans because it's the nearest and then it allows better assessment. Yeah.
Understand. Okay. So now this is the palm that you were talking about.
Yes, exactly. So I mean, in terms of physiological, pathological or structural, it can be due to the polyp, adenomyosis, fibroids, of course, underlying malignancies and hyperplasia, and the other causes could be coagulation, which is blood clotting problems, or due to the ovulatory dysfunction problems, and iatrogenic means is due to the introductions of such as intrauterine systems, or it could be due to the endometrial lining itself. Yeah, this is something that's I wouldn't say it's medical related. Yeah, and of course N is of course not classified elsewhere. It could be due to underlying like kind of malformations of vessels and all that. Yeah.
Wow. Okay. And then, so treatments. Okay. So after you find out what's going on, where do we go in from treatments here?
Yeah. Okay. So the treatment options, and I would say that it depends, like you say, underlying the pathology of this and the other one. Majority, of course, it depends on whether is it acute or is it chronic. Okay. So generally, it is very safe that we start with medical treatment. All right. Not everyone immediately will need a surgery and all that. So the first line treatment generally will be what we call the medical treatments such as tranexamic acid, okay, and the other thing is NSAIDs, okay. So what are these drugs? These drugs is something that to help with the bleeding problems, okay. So and of course the NSAIDs, everyone knows, is help with the pain as well, and you also have a synergistic effect to stop the heavy bleeding. Other treatments, if let's say if it's I would say that you can't find any structural problems, you can try of hormonal treatment. The very common one is either progesterone treatments, and of course, and also another one is birth control pills. And very I would say effective to treat a heavy bleeding one is called intrauterine system, and it's something that is put it inside the womb lining like you've seen here. So it's the lining, it helps reduce the heavy bleeding, it suppresses the ovulation in about more than 50% of the time, and it thins out the womb lining. So of course these are usually the first line.
Yep.
And of course the second line is sometimes this fails and there's no role in surgery or the risk of surgery is high, then you can give what we call injections, and it calls it GnRH injection. And if that, of course, if there's underlying problems, definitely you should go for the surgery. For example, the polyps, it's due to the underlying. When you will give the medical treatments, you will somehow just stop the problem for a while, but you will subsequently come back again. Because the polyp, I mean, my experience that once you resected it and you treat the problems, it will be fine. And I would say that later on, I probably will move on to adenomyosis and all that, fibroids and all this. Of course, if you have these two, it depends on the symptoms and fertility concern and all that. But otherwise, of course, generally, for someone with perimenopausal, a definite treatment, of course, is removal of the womb, because this is the bleeding problems. Yeah, but of course, it has to weigh pros and cons. But if, of course, is a suspicion and malignancy after the biopsy from the womb lining, yes, the definite treatment, what we call THP, means removal of the entire reproductive organs. Yeah.
So is there somebody asked this question? Are there different types of treatments for ladies who are still trying to get pregnant, and for ladies who have decided, okay, no, I'm okay, I'm done?
Okay. So again, the question is, I missed the part that.
So in terms of treatment options, right?
Yeah.
Is there different treatments for ladies who are still trying to get pregnant, and for ladies who are not trying to get pregnant or don't want to get pregnant anymore?
Yeah, definitely there will be a difference. Okay, so the easiest way would be someone who has no fertility disease, because of course, as mentioned, the problem is of course from the womb. But if you're still keen to have pregnant, you definitely need to preserve the womb. Okay, so it depends on, like, for example, what are the underlying pathology. If you don't have the pathology, of course, just medical treatment will be fine. The simplest one is over the top is that you can see the medical tranexamic acid and NSAIDs. Of course, until when you are really pregnant, they should stop that, because that you should not take this during pregnancy. Yeah. Of course, birth control pills will be contraindicated, because you're supposed to want to get pregnant and you take hormones. That doesn't make sense. But if we talk about the surgery, about something that's underlying, for example, polyp. Okay, polyp should be removed because it causes can cause implantation problems, and of course it can cause miscarriage. So this is the culprit, the bleeding problem, and of course the implantation problem. Polyp, definitely anything within the mucosa you should remove. Okay. In terms of whether adenomyosis, which is the swelling of the womb, or the fibroids, then it has to be balanced again. Because if you're going to do a surgery on the womb, it scar the uterus, it scar the entire thing, and you will need time for it to heal. So generally, my advice would be, if you do have big fibroids and you need the surgery, and you will need at least probably 9 months for the womb to heal before you try to conceive. And generally, I would say that, okay, what type of fibroids adenomyosis warrants the surgery, and which type doesn't? Yeah. It depends on, of course, if you ask me, if you have not have any children yet, and you still want to try, of course you try, but you should give your timeline, of course, like 3 months. If it doesn't succeed, then you should do something. In terms of the fibroids, generally, I would say the consensus, if it doesn't distort what we call the womb lining, generally, I think you can just omit it and just try for your pregnancy first. However, of course, if it fails, then probably you need to remove. Generally, if you, let's say, more than 5 centimeter distorting the or out of the womb, then you should remove that. That will help with the pregnancy. And in terms of adenomyosis, another condition, I probably would say that it's not so simple because there's no defined area, because this is a condition where this is similar to the endometriosis, just the condition that's just overall on the womb. So yeah, so I would say there's a role, but that's the pros and cons.
Yeah. So I mean, it's a lot of you kind of need to really understand the situation and really talk about it with your medical provider before you come to like the decision that you want to make, correct?
Yeah.
So not so simple after all. Yeah. Okay. In terms of, because you specialize in robotic surgery, what is robotic surgery in a nutshell?
Okay, so first I want to just probably clear the misconception. Most of the time when we say robotic surgery, you say, oh, it's operated by robots and all that.
Yeah.
Okay. So the thing is, when we say robotic surgery, is kind of, we say, robotic assisted laparoscopy. So generally, of course, it is what we call a keyhole surgery, but the surgeon is controlling the robots. That is already the instruments that is put into the patient and doing the surgery. So it's kind of a robotic arms, but it's controlled by the surgeon. So that we'll say that this is robotic surgery, and what are the benefits? That it is 3D visions, so we can see under the console, what we call that, and then controlling the robot's arm. And it's very, very, in terms of comparison to the laparoscopy, it is more accurate in terms of excisions. It gives you the full range of movements and while you do the surgeries. And there's also data that shows that compared to conventional laparoscopy now, that it's a lower risk in terms of complications and so that's the advantage of robots.
Wow. Okay, that's interesting. I mean, I myself have gone through robotic surgery before, so it can seem quite overwhelming when you go into the operating theater and you see this big robot with the arms on top of you, and the doctor's actually not seated next to you; it's actually further in front. Correct?
Yes. Exactly. So I mean, that's the downside. Of course, that the doctors want to be next to you, but so the arms is there, and then of course the robot arms, like you mentioned earlier. Yes. So that will be a distancing from the patient. Yeah, but generally, of course, you will still have one assistant which is next to it and doing all the rest, troubleshooting if there's any issue.
Just now when you talked about, in terms of precision and everything, some people, they probably have the, people have the concept that, if it's big, even though it's robotically assisted, are there going to be big things inside me, or is it, in terms of the comparison between a robotic assisted and a normal surgery, are the instruments used still kind of the same?
Yeah, I would say, in my opinion, we're probably about the same. Okay, so the incision in terms of conventional, the thinnest, the instruments that can go into the abdomen is what we call a 5 millimeter. Okay, what we use a 5 millimeter pot. Okay, and in terms of robot, it's about 7 millimeter. So generally, of course, as you can see from the image, the large incision will be what we call like a Vanna steel, someone who's going through a cesarean section. So that will be incision. Some, of course, can be a midline incision. That's what be. In terms of robots, you can see for the far end, generally you will need about 4 incisions at the side, and of course through the navel, that is where the camera is. So compared to the conventional, it's just that the incision slightly, I wouldn't say 2 millimeter is a lot of difference. So that's, I think something that's probably negligible. Yeah, it will be almost similar incision like a conventional.
But in terms of healing time and everything, it's definitely better than a large incision, isn't it?
Yes, definitely. So for keyhole surgery, definitely it's much better compared to a large incision in terms of pain, in terms of the hospital stay, and in terms of complications. definitely much superior. The only thing that's in my opinion that of course you will need a large incision is that when there's a large mass and all that you probably will need to struggle, using a laparoscopy because you can do the surgery, but you may need the time to extract the specimen out. So it's again balance and all that. Yeah, you wouldn't want to be too long in terms of under anesthesia as well. So it's a balance, of course. Yeah.
One final question about the robotic assisted surgery. Can all surgeons who do laparoscopic surgeries do robotic, or is it like is it a skill you have to go for training and this and that? How long training do you have to do before you can do the assisted one?
So I would say if you ask me, can all laparoscopies go for robotic? My opinion is yes, because I was a laparoscopy or the other way around, but of course it's a robotic because both has what we call a learning curve and all that. So they both have a learning curve. I personally feel the learning curve for robotic surgery is much lesser compared to laparoscopy. Yeah, because it really allows you to have similar movements to like what you operate as an open surgery, but with the arms inside the abdomen. So, and if you ask me, how long? Of course, it depends on individuals. Some, of course, are very proficient within years or months. They can be very good at in terms of surgery. But my opinion would be most of the time when in the training and all that, that's maybe more than 20 cases of surgical surgery that you have done, you will get better and better. And
So the reason I asked that is because I mean we've had ladies who have gone to obviously different doctors, and the doctor says, I still think that the normal traditional laparoscopic hysterectomy is still better, and then you have the other group who says that the robotic is still better. So obviously some don't do robotic and some do. So in terms of is there a final pros and cons that a person said, okay, maybe robotic is better, or that kind of thing?
Okay, I used to, I like I said, I do both. Okay,
yes.
I would let's say a patient comes to me and say, I would take it as a way that for example, if I have instruments of this or this to perform a surgery for you, I would give them the something that's better, like as I told you, compare what is the benefits of the robots and all that, and of course that. What is the downside or what we call the negative side of the robot? The robot, okay, in terms of the cost, of course, the robot will be more expensive. So you have to balance. So generally, I would say that I do both. In terms of, for example, if it's not the very severe kind of condition, in terms of let's say, for example, someone who had a condition of womb lining condition, hyperplasia. But the womb is actually normal size, there's no previous surgery, there's no endometriosis underlying. I think conventional surgery, it should be fine, right? Yeah, but of course, if you can afford robots, we can do the robots, definitely it's all right as well. But if, for example, another condition would be, let's say, someone who have previous 3 or 4 surgeries, they're known to have endometriosis, with deep endometriosis involving the bowel, ureters, I would definitely prefer robotic. Yeah, I wouldn't say yes, you can do a laparoscopy, but robotic would be my way to also say because of the complexity, and you can do the excisions more precise and all that. Yeah.
Fair enough. Okay, so we've kind of covered the abnormal uterine, bleeding. How about painful periods, which is the other topic that we're going to cover today? We have a good lot of girls or ladies who come to us and said, I've always had painful bleeding, and it's normal. But as the expert, is it normal?
Okay, I would say maybe I'm biased, but actually to me, any painful period is abnormal until proven otherwise. So that you should see the doctor for that. Okay, so when it comes to period, like you said, it's the stigma or the normalization occurs. You can say, and your sister or your mom will say, okay, period is normal, if you have cramps, it's all right, definitely, you don't have to worry. And it's categorized, I would say, that primary and the secondary. Okay, so there's a category, of course, that the pain is the primary is due to the prostaglandin or the chemicals that's produced during each cycles of the period, and of course, and the bleeding, cycles associated with the contractions of the womb. So this will be a primary if there's no underlying pathology. Generally, this category of pain shouldn't be very excruciating, and there's always say in our medical term is that during this period pain will improve once you're actually giving birth and all that. So yeah, so that's usually because I think the theory behind is because once you go through the labor and you have experienced the worst pain you ever had, probably that could be the one, and then you kind of adapt. And this kind of a small, not no obvious underlying pathology will not be a concern anymore. So I would say that yes, but like you said, if you have period pain, it's progressing worsening, it should be abnormal until period otherwise, and then you should seek medical treatments and then or advice. Yeah. So in terms of the primary or what we call primary dysmenorrhea, like I mentioned earlier, the pain that is not due to underlying pathology, presumably you can take some painkillers, and then of course it improves, then you don't have to worry. And this is usually the typical one, like a Panadol and NSAIDs. And as mentioned earlier, it should improve after childbirth. And of course, it can also be controlled with birth control pills. So, for example, that you will need a birth control pills. Then you have some pain. Yes, you can by all means take birth control pills. Other complementaries, usually with exercise, yoga, and all that, this would help with your pain. And of course, if it doesn't, then yes, like you said, you must find out what is the underlying cause. The most common, of course, if you ask me, it will be you need to rule endometriosis. All right. So because this is one of my special interests, of course, is the bias. But then this is one of the commonest painful condition for gynecology condition. Yeah. So we're probably going to touch on that, right? So yeah. So I think that's
So this is when you talk about the. Okay, just coming back again. So on a scale of 1 to 10, I mean, like in terms of the primary one that you talked about, because I mean, I know so many people who have. This is something that trying to get a clearer idea. So with so many ladies having period pains, as long as it's bearable, that means if it's so pain that they can't even, like, let's say for example in school they can't go to school when they have the periods and everything. Is this considered primary or secondary?
No, if it's someone if that pain until they can't go to work, can't go to school, you got to rule out other causes. It cannot be primary, in my opinion. So yeah, in primary, I mean, like as I said, some Panadols, of course, the cramps. It shouldn't be until the stage, you see, because it's due to the chemicals, the mechanism of the period that it comes out and all that. So it should not be pain until this degree. Yeah.
Yeah. So it shouldn't be pain that you can't function on a day-to-day basis.
Exactly.
Okay. All right, and then so then let's go on to the secondary. So secondary, just now you kind of mentioned these things, right?
Yeah.
So apart from pain, what else? Yeah.
Okay. So in terms of secondary, of course, then how do we know that like I said, period pain is abnormal? Because that like I said, apart from that, the degree of it, all right, we need to find out. Is it associated with other conditions? All right. So the timing and severity, I would say, like you say, the degree, if it's pain 10 out of 10, I would usually use what we call visual analog scale, 1 to 10. 10 is definitely you're gonna come over anyway. You're gonna collapse anytime. That is absolutely. But you need to find out what is the underlying pathology, and other conditions such as the pain associated with sexual intercourse. And of course, if you have any history of infections, that could be a contributor to the pain, and of course, underlying other pathologies such as irritable bowel syndromes and a previous surgery, that could be the factors of a pain if you have any of it. So, in terms of when we want to find out whether it's any secondary, we need to rule out, in other words, rule out other causes as well. So it can be due because there's bowel within, there's bladder, there's ureters. These are the things that we need to rule out from a gynecological viewpoint. And then from the gynae viewpoint as well, we need to rule out something pathological. Is of course earlier on we mentioned the abnormal uterine bleeding, which is bleeding in between the period, and of course the bleeding of the sexual and the prolonged bleeding. This is very important. And generally, I would say in secondary dysmenorrhea or painful period, we definitely need to find out, is it due to endometriosis? Because this is one of the commonest. All right, it's I would say that 10%. In terms of the prevalence, in other words, generally women who have period pain, I would say generally 10% women has it. It varies. Of course, some will have pain, some may not have pain. So, and generally, of course, it's a benign condition. I can see from here the common causes of period pain, the secondary. So endometriosis would be top of the list, and then the second one would be adenomyosis. All right. Earlier on, we touched about adenomyosis, but what is MS? Later on, we'll move on to that. And of course, there's some of the fibroids that can also cause pain, right? So most of the time, those are within the womb lining, or we call submucosa, and some of it could be what we call the external layer one. This is called pedunculated. Probably I will touch on that. And of course, the last but not least, is an infection. Yeah. So, and before we're going to move on to the endometriosis, the next slide will be showing you is actually, these are the few root cases and all that. So this actually on an ultrasound, what we call a ground glass appearance. So when someone comes in so much pain, of course you will, apart from the history, assessment, physical examination, ultrasound is mentioned earlier, is very important. And the scan with this one showed that it's a what we call endometriotic cyst. It's a blood cyst, and you can see earlier also on the right side, that's when the surgery happened. This is the chocolate content that comes out, and the bottom part is as well, and it also shows that what are the causes of endometriosis due to the retrograde menses. And moving on, if you see the next slide, if you can, it's another also kind of a root case that's due to the submucosal fibroid. This is the fibroid within the cavity causing the pain and abnormal uterine bleeding. So these are the few examples that can cause the pain that you need to rule out when the pain is getting worse and worse. So we'll move on to any question. Now we'll move on to endometriosis.
Yeah, there are some questions, but I can ask you. Okay, hold on. There's one question. Hydrosalpinx. So somebody's just asking. They have suspected hydrosalpinx. What is hydrosalpinx, and what would you suggest to remove it?
Okay. Okay. So hydro, we know is water. Generally, we say it's water. But in terms of ultrasound, like earlier you've seen, there are categories of the degree of the reflection, because ultrasound it's actually through what you see behind. So anything that is water will be black in color. So any more dense, it become whiter. So some in between, like the blood, just now you should show it's what we call low level echoes in between. So when hydrosalpinx means tube, means it's actually like suspected will be a swollen tube, or we call water within the tube. It can be many causes, sometimes we don't know, but generally we want to rule out is infection, because infection causes adhesions that it got blocked and becomes swollen. So that generally is the first. Of course, it can be also the blood that's blocked inside, or could becomes hematosalpinx. Sometimes you can't really discern between the ultrasound. So I would say hydrosalpinx, if it's hard to say that you need to do anything about it. So it's generally have to go through again, like histories and all that, because I have encountered when it's a hydrosalpinx, it turned out to be primary tubal cancer. So yeah, exactly. So it is a series of not just that. Okay, we have the scan. What is this? So it's not just so like based on just one category of the findings. It had to be really holistic and then see from it directly.
So a lot more research or a lot more scanning. Things have to be gone through before you kind of decide what's going to happen there.
Right, yeah.
Understand. Okay. All right. Let's go on to endometriosis, which is a very interesting topic.
Yeah. So as we all know, I mean, I would think most of us now know what is endometriosis, but it still had to be put an emphasis. So like the definition of it itself is endo means the womb lining, okay, and it deposits outside of the womb. So generally, of course, you can deposit within the womb, the pelvis, the ovaries, the tubes. These are the common because within the pelvis, and it is a common condition. I mentioned earlier is 1 in 10, about 10%. So yeah. So of course that if you ask me, most of the people will know or not. I mean, still, I think we should raise awareness, because if you ask someone, do you know what is diabetes?
Yeah.
I think almost 100% know what is diabetes, right? Because diabetes is about 10%. All right. So if you say endometriosis is 10%, why shouldn't all people know about endometriosis? So I think that's something that we need to emphasize on. And the effects when you're in the reproductive age, and it's estrogen dependent condition. So as mentioned earlier, what are the symptoms? It varies. Okay. I would say that some may not have symptoms, even with endometriosis, they may not have symptoms. And some with minimal endometriosis can have a lot of symptoms and all that. So, and how we're going to diagnose endometriosis mainly, not just about the ultrasound. Now it's important about the symptoms. Okay, so early on, of course, the painful period is one of it, and with the cyclical pattern and all that, and other conditions such as bowel symptoms. And all that. So, what is the causes of endometriosis? I mean, as you can see, what is retrograde menses? Earlier on, you saw the picture. So when we say retrograde, means it's the backflow of the period. So this is still the theory pushed, I think, back in the, if I'm not wrong, 80s by Samson. Samson is a famous gynecologist. So he found that the backflow, when he did a laparoscopy or surgery, found that's the backflow of the period. So this postulated theory is that because of backflow, the womb lining deposited outside of the womb. And slowly with each cycles of period, same thing, like a period within the womb, which have period, right? So every cycle it bleeds as well. So blood is irritant to our body. So it continues to cause inflammation, bleeding, accumulation. So that's when it deposits on ovary, it kind of responds to estrogen. Each cycle continue grow and grow. So other theory would be like vascular due to rare cases it can be found under diaphragm or even other places of not within the pelvis and the upper abdomen. And other condition, metaplasia, is because that it could have been there since childbirth and all that. It's only when when you start to have menses, you respond to the hormones, that it starts to grow. And of course, genetic predisposition and hormonal dysfunction. So the next will be, if you can see, it's like kind of show you the retrograde menses. The next slide will be just a kind of a video to show you, that how this kind of endometriosis looks like. Slowly backflow, and then the deposition of this small endometrial tissues within the pelvic cavity, and slowly responds each cycles, and it become a worsened condition and all that. So where are the sites? It can be, as mentioned earlier, within the pelvis. Usually it's quite common, because it can also be other places. Happen in with the surgery. Someone who have endometriosis on the appendix. Yeah. So and they also have under the diaphragm. They can have symptoms of what we call cyclical pain. So these are the endometriosis that can happen within the abdomen.
Interesting. I never knew that the tubes had the opening. I always thought they were connected and there was no opening on the other side. So when we talk about backflow, I could never understand where the backflow. But this is a really good video that gives you a better clear. Oh, interesting. Okay, just to go back just now, Rachel. Just now the genetic predisposition. Does that mean that, let's say, if I was to have endometriosis, there's a higher likeliness of my daughter or grandchildren down there getting endometriosis as well?
Okay, I would say the first degree, like for example, you say your daughter or even your mom who has endometriosis, you're high likely you will have endometriosis, or even your sisters. So I'm going to move on to risk factors. Okay, what you say genetic predisposition? There's some data that shows because of the genetic setup, that's during the process of production of some enzymes and all that, which is lacking, like I mentioned earlier. It could be because of the hormonal dysregulations and all that. Yes, then you are more predisposed to endometriosis. So if you have family history, yes, you are a stronger risk factor. So if, let's say, your sister or your mom had previous history or endometriosis and had surgery, and now you have a pain, I would say, I think it's endometriosis, that kind of thing.
Understand. Okay. All right. So sites of endometriosis, we kind of went through this just now, right?
Yeah, I think that we went through this. So I think the sites can be, and I think that this probably, I would say that, as I mentioned earlier, I think these are the endometriosis within the body that it's due to the inflammations. It slowly grows and it kind of causes scarring. And I think probably the next will be is good at, in terms of the progression of it. It's generally, I would say, that's categorized into minimal, mild, moderate, severe. And when we're trying to categorize this, is actually mainly to say actually not so much of the disease itself, because I mentioned earlier you can have mild condition, but you have severe pain. So it's not so much the category, oh, you have severe pain, definitely it's severe condition.
Yeah.
So this actually is the developed or this category or stages of endometriosis is more for fertility. So, but I won't touch on the fertility because that's another topic. So, but it can coexist together. You can have what we call a severe condition, the deep endometriosis, and you can have, of course, the cyst, what we call endometrioma, and you can have the superficial endometriosis, what we call peritoneal endometriosis. So this three cycle. So what are the risk factors? Okay, you will have, like I mentioned earlier, of course, retrograde menses is the theorized factors of it. So early menarche means the earlier you have the menses, the possibility, of course, each cycle that happens, and late menopause, same thing. And short menstrual cycle, of course, the more period you have, then without having a children, this is risk factors. Heavy menstrual bleeding, and of course, if you have obstructions, there's no way going down, but then it's only backflow. We have seen some encounters of this. Then the womb was swollen, the whole bloods were collected, and then of course the endometriosis, the backflow and all that causes the pain and all that. As mentioned earlier, family history. So how is it all endometriosis diagnosed? As mentioned earlier,
This is the big question.
Yeah.
This is the biggest question we have here.
So how is it diagnosed? So, I mean, generally, I would say that the gold standard used to be years back is surgery, right? Because you say pain and all that, it can be normal and all that, but until you do a diagnosis of the keyhole or even the open surgery, you biopsy that area and then you send for histology, then yes, you have endometriosis. That used to be the gold standard. But now we move on to, we know this more, and generally it causes the symptoms, and we have a series of kind of a question to answer. For example, in my category will be that 4Ds and 1C, which is what we call dysmenorrhea, which is a painful period, which is cyclical, and dyspareunia is usually associated with pain during sexual intercourse, and dyschezia is actually pain when during period you have pain when you're trying to open your bowel, and dysuria or frequency is associated with bladder. You can have pain when you're about, but then of course after all you said earlier that how the pathology of endometriosis can cause chronic inflammation, and you can eventually have chronic pelvic pain. So these are the few things, and it can also cause other symptoms such as, of course, all this causes inflammation and that you can have lower back pain, pain radius to the legs. These are the symptoms, and fatigue because of the pain, and infertility is also part of the criteria to diagnose. So of course, history is one. Of course, coming to the examination, and then I would say the examination wise that depends on whether we can do internal check, because that will give a lot of information. Whether it's this and the tenderness, and of course the pelvic ultrasound. As mentioned earlier, of course, to diagnose it used to be conventional needle biopsy, laparoscopy. So what to expect? And again, like earlier on, you will have the gynecologist or the doctor will ask you a thorough history to rule out other causes, and then to pinpoint what exactly is it. Any specific all the the symptoms that I have mentioned earlier, all the Ds and the Cs and the condition, and then of course the examination will be. I would say the most important to me, if you are of course sexually active, the internal examination to elicit where exactly the pain is. So generally, the pain will be in what we call the admixal or uterosacral, which is the part that we will examine. And the most important is the ultrasound. So generally, ultrasound will be the abdominal or transvaginal ultrasound. I personally feel, of course, that transvaginal ultrasound, because someone is sexually active, you can do that, and to give you a lot of information, because what we're going to do, actually, the next slide you see that how the ultrasounds, transvaginal ultrasounds is done. I think another one, yeah. So you can see, of course, that there's a this slide is comfortable with that, and then the assessment on the abdomen. This is to check on whether is there any adhesions, and what we call this a sliding sign, to assess the mobility of the womb. Is there any tenderness? Is there any mass? Yeah. So with all this informations and all that, then we will decide whether you have endometriosis. What's the next step of the treatment options?
How young can you actually diagnose? What's your youngest patient, in terms of diagnosing endometriosis?
Okay, I have the youngest, if I'm not wrong, 14, 13,
Wow.
13, 14. Mm.
So that means it doesn't matter how long you've started your period. So, because I mean, obviously for the 14-year-old, she wouldn't have had her period for very long.
Yeah.
So it doesn't, the actual time frame, that because I mean, I used to think that, the older you get, the more chances of you getting endometriosis.
Yeah.
So it's no such thing in that sense.
Yeah. So there's no, of course, if you ask me, whether I should do a surgeries and all that, I would say that, I have this 14 years old have surgery. But let's say if you're someone who comes with the symptoms and all that, I don't think I would definitely the first instance I would say, you do surgery to do, because, they're young and all that. So with symptoms based, of course, they may have slightly different other symptoms. So generally, if they are younger, they may have what we call the gastric symptoms. They may have epigastric pain. Yeah. So these are one of the commoner symptoms I see for a younger age group that they have. So now you can see that, of course, that you can have period pain. Of course, it's worsening.
Yeah.
And generally, if it's over the counter, the drugs that is helpful, then there will, of course, observation. But just now, like you said, there's data to show that in terms of endometriosis, when that's diagnosis, do the diagnosis, there's always a delay up to 6-7 years. And of course, if you have family history, moms have known this before, they probably will have brought the doctor to see a gynecologist and get this treated and then diagnosed. And if it's not, if they see a primary physician, they will rule out other causes, then start treatments. Sometimes with all this, the delays can be as long as 7 years for the endometriosis to be done. Yeah. So and you can see that the next part will be, of course, endometriosis not just causes the pain, it can cause a fertility problem as well.
Yeah.
So that will be coming to the part that now you have endometriosis, what should be done. So I think the next slide, I think is just mentioned. Okay, why is it important to diagnose? It's why it's so critical.
Yeah.
It's mainly, of course, one is to explain the pain, because you can't explain what the pain is. Why is it so much pain?
Yeah.
You need to provide validation. You need to reduce this isolation. Oh, now you have this condition, it's endometriosis. Now you know why is it having so much pain, and of course provide early treatment. You don't want. You should not suffer. I mean, you should not suffer from this. Of course, there's always treatment there, and the impact of it. Of course, the longer that you delay, it can causes further fertility problems, more pain, and all that. So, as I mentioned earlier, this one is to show that actually it's a chronic condition, all right, and it's as common as type 2 diabetes, Crohn's, other arthritis, and it's it should be treated carefully and it's earlier, and to reduce the pain. So
it's definitely something that I think a lot of women need to kind of know more about. I never learned about this until I went through infertility, and I think I speak for a lot of ladies in our group that most of them had no idea what this was. So that's why we often get asked, what is endo?
Yeah.
So
I think that treatment options, I think it's the most important, because let's say, okay, I have this condition, so what now? All right. Yeah. So generally, this is, of course, if it's, I mean, put to another extreme, of course, if it's something that's very bad, critical cancer, that you need surgery, you need chemo and all that. But it comes to endometriosis, yes, what is the priority? In my opinion, of course, there's always three things that before you offer the treatment. Is there pain? Okay, so pain, because endometriosis causes pain. Second, is that whether fertility is a concern? Because, as you know, all right, this can cause the fertility problems. And third would be, whether you need this is the surgery, whether you need the surgery. So whether these three things are the most important. So if it's, of course, that you have no symptoms, I think also underlying what are the conditions that are five things we will say. If there's no presence of pain, there's very small cysts, of course you can still observe.
Yeah.
And if you have no fertility desire, of course you can observe. But it depends on the age and, of course, recurrent endometriosis. Most of the time, as mentioned earlier, endometriosis, they are not cancerous, of course. But if you have suspicions that sometimes cancer can happen, yes, you will need surgery, surgical intervention. So these treatment options that, as mentioned earlier, like the painkillers, if it don't want a surgery, yes. Then hormonal treatments that's to suppress it. Of course, it's conservative in terms of surgery. there are two types. One is conservative without fertility concern. Then, of course, you exercise the condition, then preserve as much and restore the anatomy. And of course, it's radical, it's due to the pain, there's no fertility desire. Of course, the definite treatment will be exercise as much or even do removing the whole reproductive organs.
In terms of endo, let's say if you were to get rid of it through surgery and everything, can it come back?
Yes. So it depends on whether is that how radical it is. So as a surgeon, of course, we will definitely exercise as much and balance the risk. Of course, if you do have, that's why the symptoms comes into play. If you have a lot of bowel symptoms, sometimes it's not just the gynecologist will be doing the surgery because you need to exercise and treat your symptoms. You may involve the bowel surgeons to remove most of the disease there, even the ureters or even the bladder. So that's why the symptoms is very important before, even as sometimes I would say MRI imaging will be required, even pre-op assessment and all that. So and I would say that if you, let's say you have conservative surgery, yes, the endometriosis will recur. If you have conservative surgery and you want fertility, I think I would say that as soon as possible after the surgery, you should get pregnant. That would be the, there's data to show that after the surgery, you increase your fertility. And if let's say if you don't, you should be on a medical treatment to suppress and prevent endometriosis. There's data to show that if you don't, 10% each year, so that means after 1 year, 10% risk recurs, up to 50 to 60% after 5 years. So it's kind of like, it's okay. Unless, of course, you're menopause, then, of course, it's estrogen dependent, then you may not have the risk of recurrence.
Understand. Okay. All right. So now then we obviously go on to, adenomyosis, right?
Yeah. Okay. So I think that's adenomyosis. I would say that is sister of endometriosis. I always use that because that is like the definition here is actually the endometrial tissues that goes into the muscle of the womb. So the other one as an endometriosis is outside the womb. So this category of condition can also causes severe pain. All right. So generally, it's how it diagnosed. It depends, of course, the symptoms as well, and there's always imaging to diagnose this.
Yeah.
So I wouldn't want to go into details of how it is, but generally, if you do a scan, that's asymmetrical womb condition. That the front is thicker than the back. That there's always and there's no obvious signs of fibroids. Then yes, it's probably adenomyosis. So and again, of course, the symptoms can vary, but majority, probably about 2/3, will complain of heavy and painful period. And it can also coexist. I would say 30% will coexist with endometriosis, and the symptoms can be masked by just endometriosis condition and all that. And other condition is that when you have this adenomyosis, may be associated with infertility as well as miscarriage, because it is somehow also a place where harbor the pregnancy, where the pregnancy has to be. So miscarriage is also one of the risks. So I think moving on would be how would you diagnose apart from imaging and history, is that again you need to rule out other causes, and the clinical history would be important. And I mentioned this one earlier, the symptoms that you have, and generally these are the things that's nothing much different from endometriosis. You need to rule out the causes of the pain and all that, and rule out whether infections and all that. So in terms of imaging, I would say that coming to the adenomyosis, usually I would say it's quite accurate. All right. So in terms of the imaging, ultrasound will give you about 80% sensitivity and 50% specificity. Of course, it's still operator dependent. Generally, majority of the gynecologists will know, this is a fibroid adenomyosis and all that. And of course, it's still operator. The most accurate one will be MRI. MRI gives you about 80% sensitivity and 90% because they look at the thickening of the junctional zone beyond 10 millimeter. This is suggestive signs of adenomyosis. So the next slide will show actually there are different types of adenomyosis as well. So it can be a very globally, which is a diffuse one. It can be a very focal one, and it can be also internal or external. I won't go into the details in terms of this because to many of us, even we say adenomyosis, that's a condition, whether how to treat the symptoms and all that. So the next one will be just to show that how the condition is on the imagings, and So the treatment options is nothing much different, and again, so would be the three things as well. So would be whether it's going to be pain or not. Okay, of course, if you have adenomyosis and you have nothing, no symptoms, no heavy bleeding, I mean, you don't have to. It's benign condition. You just observe and all that.
Yeah.
Because once you reach menopause, it's not an issue. Second, of course, fertility. All right, fertility is also you can have very severe adenomyosis and then you're trying to conceive, but the risk of miscarriage happens. And what's the next step? And third, of course, that I mentioned earlier is that whether you're willing to undergo the surgery. Yeah. So these are the three categories and all that. If not, of course, conservative would be the just analgesics and the hormonal. And another category, you say that the treatment is HIFU. HIFU stands for high intensity focused ultrasound. So generally, I find it's very useful for someone who conserve the uterus and wants to get pregnant, because what this HIFU helps is actually it burns the area and it kind of makes this conditions suppressed, and then for you to get pregnant within the time frame. And of course, there's no obvious downtime compared to the surgery. And again, this is not much different compared to endometriosis, and of course,
Similar.
So it's quite similar. The only thing concerned is, of course, is the surgery. When the surgery is alright, maybe this can remove that. It's awful. Okay, why I want to put that is actually if you have conservative, alright, it will be like a fibroid. You're going to remove that part and then reconstruct the womb, and you need to let it heal. But generally, if you have no fertility desire, of course, removing the whole entire womb will solve the problem.
Yes, understand.
Yeah. So I think in summary, I would say that abnormal uterine bleeding in fertile period is quite common, and of course you need to find out if you have any of it until proven otherwise. It's normal. And important is, of course, like you say, increasing awareness. Let people know, abnormal bleeding is common as well. You should seek advice when you should seek advice, and recognizing the symptoms, having early investigation and treatment. Seek treatment, and of course, have long-term discussion about this. Like I said, endometriosis can recur. So, what is the long-term plan? And and the counseling of underlying condition.
Wow. Okay. What an influx of information tonight. But I think at the end of the day, the whole point, as you said, is awareness. To know what is normal and what is not normal, and kind of when to seek for advice from the medical. Medical doctors and this and that. So I think it's been very interesting. I've learned a lot of stuff tonight as well.
I hope you're interesting and informative, most importantly.
Yes. And I think that at the end of the day, it's also, it's awareness for us for the next generation as well. It's not so much, for us in terms of, we're probably in our group, most of us are facing it because of infertility. But it's also awareness to know that for our next generation, there's a lot of things that we should understand more before we can, have the next generation.
Yeah.
But thank you so much, Dr. Andy. It's been very informative. We'd love to have a chat with you, in further detail of endo and adenomyosis once again. But thank you for your time. And,
thank you very much. Yeah, I truly enjoyed
if there's any, sorry.
Well, no, I was just trying to say that, thank you, because when it comes to all this talk and endometriosis and pelvic pain, it's my favorite. It's like kind of a passion when you ask me about it. I can talk non-stop for hours and all that, and then you ask me information. Yeah. Of course, there's still many things.
Yes, for sure.
Yeah.
No, there's still so much to learn. This is just, we're only really just at the top of it. So, hopefully we can have a further chat one day regarding the further information. But thank you for your time. It's time for you to go home, I guess.
Yeah, thank you very much.
Yeah. If there's any questions that we have from our followers and everything, we will send them along to you so you can just, address them and this and that. But thank you everybody for tuning in today. And, Dr. Andy Tan is located with Sincere Healthcare Group at Gleneagles Hospital. You can just Google him and you'll find information. And Dr. Andy Tan, where is your, specifically Gleneagles, what floor and everything?
Okay. I'm located at Annex Block 0, Level 3, 0332C. So yeah, if you Google it and then find through the Sincere Health Group you can find me as well. Yeah.
Great. Thank you very much. And we thank Sincere Group, who are always very supportive of doing talks with us. Thank you, Dr. Andy Tan, and we wish you a very good night.
Thank you very much. Bye and good night.
All right. Good night, everybody. See you next week. Bye.